So it's now my pleasure to introduce Dr. Naomi Dempsey from Miami Cancer Institute. She'll be discussing ctDNA in breast cancer. Take it away.
Thank you. All right, so in the next 15 minutes, I am going to give you a whirlwind tour of all of the new and emerging applications for ctDNA in breast cancer. Here are my disclosures. So our objectives are first to define exactly what is circulating tumor DNA, some of the assays that we're using, because they are different for different settings and for different questions. Kind of starting with the most well-known and approved kind of uses would be for treatment selection in metastatic breast cancer. We'll also talk about utility in treatment monitoring, monitoring for recurrence, and breast cancer screening. So what is circulating tumor DNA? It is a type of cell-free DNA, which are DNA fragments that are circulating in the bloodstream. And so circulating tumor DNA is just one type of cell-free DNA. And usually it comes about by apoptosis of tumor cells. And these can either be from the primary tumor in tissue or from circulating tumor cells. Most cell-free DNA is actually released by normal leukocytes. So it's important to separate out what is actually the circulating tumor DNA fraction of the cell-free DNA. And we tend to see higher levels of circulating tumor DNA when there is higher burden of disease, when there is liver metastasis, and in certain cancer subtypes. For instance, more likely that we would see circulating tumor DNA in a triple negative or in aggressive HER2 positive, and less so in your kind of more indolent ER positive HER2 negative breast cancer. And it's important to talk about the assays for ctDNA because really you'll use a different assay depending on which question you're asking. So there's a few different approaches. The digital droplet PCR is basically where you're telling it what mutation you are looking for, and it's only going to tell you about that mutation. So an advantage here is that it's very sensitive for identifying that mutation, and it's easy to interpret, it's lower cost, but the disadvantage is that you're not going to get a whole panel, you're only going to get the mutation that you're looking for. And you need to know which mutation you're looking for in order to use that. The cancer panel testing is more what we're used to seeing with, say your Guardant testing, liquid biopsy. It's a next generation sequencing based analysis of some selected mutations. You tell it what tumor type you're looking for, and then it will probe, certain mutations. So it is broader. It's able to assess microsatellite instability, TMB, which I'll put a little asterisk there. We'll talk about TMB. And then things like NTRK. So it's a nice balance between looking at a number of mutations and having decent sensitivity. One of the drawbacks is that we just have to make sure that we know how to interpret some of the data for things like clonal hematopoiesis of indeterminate potential. And then whole exome sequencing is kind of the broadest application, but then also the lowest sensitivity. This kind of shows this trade-off, this balance, that when you're doing whole exome sequencing, you've got broad nucleotide coverage, but you've got low sensitivity. Droplet digital PCR, kind of the opposite situation, and our panel testing is a nice balance. So it's important to look at the concordance between tissue, next generation sequencing, and circulating tumor DNA, because we want to make sure that when we're relying on a ctDNA assay, that it is accurate. And so in general, the sensitivity of circulating tumor DNA is really quite good, particularly for clonal mutations, meaning mutations that have been present since the primary tumor or since the initial tumor. And when we're talking about subclonal mutations, for instance, like ESR1 mutations that develop during the course of treatment, the concordance is a little bit lower. So looking specifically now at circulating tumor DNA in metastatic breast cancer, again, the most kind of established application is predicting response to therapy. We can also use it to monitor response to therapy to give us some ideas about prognosis. And it's got some interesting applications for looking at mechanisms of resistance. So We saw in Dr. Matani's talk a lot of different options for targeted therapy, particularly in the estrogen receptor positive, HER2 negative subgroup, but some of these also apply to other types of breast cancer. And so all of the biomarkers on the left in general can be found by ctDNA, including, your germline BRCA would show up as a somatic mutation that you would see on your ctDNA, but at a level where it suggests to you maybe there's a germline mutation, and thus, if they've not already had genetic testing, would want to do germline genetic testing if you see BRCA on your ctDNA. I would like to give a caveat here about TMB on circulating tumor DNA, because our liquid biopsies do tend to overestimate TMB on the order of like 1.5 to 2 times. So our cutoff for high TMB in breast cancer is over a tumor mutation burden of 10. And I would suggest that the rule of thumb is kind of something like looking at a cutoff of 20 if you're using ctDNA, that if it's over 20, then it truly is a high TMB, and we can expect some response from pembrolizumab. Certainly if you're scraping the bottom of the barrel of your treatment options and you're just kind of looking for anything to get approved, you can probably still get it approved on the basis of a TMB of 10, but just for you to understand that you may not see the kind of efficacy we're hoping with pembrolizumab if you're relying on a TMB of 10 from circulating tumor DNA. So in terms of prognosis for metastatic breast cancer, this is actually at this point an old study. It's 10 years old, but it was a prospective analysis of 30 patients with metastatic breast cancer, and they were able to identify circulating tumor DNA in 29 of those patients, and they found that the level of the quantification of the circulating tumor DNA did predict overall survival, with those with the highest levels of ctDNA having the worst overall survival. This study was done before we had a lot of our different targeted options. A lot has happened in the last 10 years, so would hope that we are better harnessing some of those mutations now to give targeted therapies, and that these numbers would now look better. So in the same study, they looked at circulating tumor DNA for monitoring patients with metastatic breast cancer. And one of their conclusions was that ctDNA was more robust than monitoring with tumor markers. They tended to see rises in ctDNA before seeing progression on imaging. So I personally am not routinely using ctDNA to monitor all of my metastatic breast cancer patients, but we all have some patients where their tumor markers are negative or their tumor markers don't really seem to track with disease. And that may be someone who, a Signatera type of assay could be helpful as an additional way to determine, whether or not they're responding to your treatment. We all have some patients where their imaging can be kind of confusing if they've got bone-only disease and you're not really, having much success with imaging, you're feeling like you're not sure if you can trust it. ctDNA may be a nice way to augment your monitoring strategy. So talking a little bit about mechanisms of resistance in the metastatic setting, an interesting trial that used ctDNA for monitoring resistance was the PATA-1 trial. This looked at patients with first-line metastatic ER-positive, HER2-negative breast cancer, and looked for ESR1 mutations during their first-line treatment with AI and palbociclib. And if they developed a new ESR1 mutation or a rising ESR1 mutation without evidence of progression of disease, they were then randomized to continuing their AI plus palbociclib or changing to fulvestrant plus palbociclib. And the results did show a progression-free survival benefit from the switch method with a hazard ratio of 0.61. This is not something that's really been adopted in standard clinical practice on the basis of these results, but I do think it's interesting in kind of illustrating the ways that we can use circulating tumor DNA to look at mechanisms of resistance. And again, this was looking at ESR1 mutations, and we now know that we've got other better strategies than fulvestrant for patients with ESR1 mutations, such as elacestrant. So I think that this is certainly hypothesis generating. In her slides, Dr. Matani also pointed out about certain ESR1 mutations themselves are showing emerging treatment resistance. The Y537S ESR1 mutation in particular is one that tends to develop with treatment with fulvestrant and can predict that they're developing resistance to the fulvestrant. So I think, again, this isn't something we're kind of standardly doing in practice, but it is of interest. There are some challenges in terms of interpreting your circulating tumor DNA. And I think particularly this is talking about your Guardant liquid biopsy panel. One of those is clonal hematopoiesis of indeterminate potential, these mutations that develop in leukocytes that don't reach the level of like a myelodysplastic syndrome or a leukemia, but can be found on your circulating tumor DNA. Some companies will, to some degree, filter for this, but the mutations that you see here, which again we kind of think of with myeloid malignancies, are ones that should signal to you that this is probably more of CHIP rather than a breast cancer-related mutation, DNMT3A, TET2, JAK2, so would not consider those to be breast cancer-related. And then false negatives are something that we deal with ctDNA, particularly if the patient's responding well to treatment, they may not be shedding much circulating tumor DNA. So really the best time to do this is when the patient is progressing. If they have a low burden of disease overall, if their disease is confined to the brain or the bones, you may not see circulating tumor DNA, and those lower tumor shedding cancers that we were discussing. So now moving on to circulating tumor DNA in primary breast cancer, which I would say is a little bit more controversial. There are applications in terms of monitoring for recurrence, monitoring response to therapy, say in the neoadjuvant setting, prediction of pathologic complete response, and augmenting our screening strategies. So from a hypothesis generating standpoint, there are a number of different areas where we could see ctDNA maybe helping us in primary breast cancer, such as being added into our staging algorithm, or to monitor response to neoadjuvant therapy, or in detection of minimal residual disease in the adjuvant setting. And I know certainly there are some breast oncologists that are using this strategy of identifying minimal residual disease, basically that an assay such as the Signatera assay would take the primary tumor, look at the mutations that are in it, and then develop a probe that then can be used for blood testing in the adjuvant setting to look for emergence of those mutations. And I think nobody doubts that it's important in terms of prognosis whether or not you detect minimal residual disease in the adjuvant setting. We know that those with ctDNA positivity have a higher chance of relapse, and the positive predictive value is very good. The negative predictive value is lower, and it may just be because they're not shedding tumor into the bloodstream, and so that's why the Signatera assay recommends that you do multiple blood draws to look for this. I think this is interesting, but we don't really know what to do with this information right now. You find that someone has circulating tumor DNA in the adjuvant setting, but we don't really have any data to suggest what we should do differently. So I think this kind of just makes patients anxious, and we don't really have a way to intervene, but I think this area is really ripe for clinical investigation. And then I would say the most kind of controversial use of ctDNA in breast cancer is for screening. This study using the Thrive CancerSeq assay was looking to screen for a number of different types of tumors, and it was using genes such as KRAS, NRAS, PIK3CA, protein biomarkers like the tumor markers that we commonly use in the metastatic setting. And it actually found a number of different cancers. However, I don't think the application is quite as important in breast cancer because we have such good screening. And when you look at the breast group here, most of the breast cancers that were detected during the study were detected by our standard screening techniques and not by this Thrive Cancer-Seq assay. Similar for the Grail Gallery test, it's a targeted methylation assay. And the breast cancer sensitivity for screening was on the order of about a third. So really interesting for some other tumor types that don't have a good screening method. I'm not sure that this is necessarily adding a whole lot in breast cancer. So conclusions are that an NGS-based panel testing really should be done in all patients with metastatic hormone receptor positive HER2 negative breast cancer, and I would argue that the best time to do that would be on progression from first line CDK and endocrine therapy because it can guide your second line treatment. ctDNA could be considered as an adjunct for monitoring metastatic disease, in addition to imaging and maybe along with or in place of tumor markers in selected situations. And then ctDNA use in the primary setting for MRD detection and for breast cancer screening are certainly interesting, but not yet ready for routine use in the clinic. Thank you.